My last introduction is someone very near and dear to my heart, Dr. Judah Friedman. He, as well, is a Cleveland native, so we don't have to convert him to a Buckeye fan today. He did his bachelor's at Princeton, and his medical education was through Case Western Reserve. I've known him since he's in fellowship with us at UH. He also did fellowship trained at University of Michigan, a reoccurring theme here today. And he is mainly at our Geauga Seidman Cancer location. His topic today is going to be treatment for reoccurrent prostate cancer. So please help me in welcoming Dr. Friedman.
Thank you, Sue.
Sure.
Thank you, Sue, for that wonderful introduction, and to Sandy for inviting me out to speak today. It's a great opportunity. I hope everybody can hear me in the back. We're good? Okay. So I am a general hematologist oncologist with University Hospitals, and I've worked for the last 15 years out at mostly out at Geauga Hospital. As we all know, prostate cancer is one of the most common cancers to affect men, and so it's definitely it's a large part of my daily practice. So I hope I can give you guys a general overview of the day in and day out treatment of prostate cancer. It's kind of the issues that I think about when I'm trying to pick the best treatment for my patients. And a lot of the topics that we'll cover have been covered already, but maybe you'll get a little bit of a different format, different perspective there. Some of the definitions, I think it's really confusing as a not only as a physician when we're learning how to take care of people, but also for patients when they're coming across these different disease states, so to speak. Is a couple of definitions are biochemical recurrence that we'll cover today. We'll talk about castrate-sensitive disease versus castrate-resistant disease. And then we'll also talk about androgen deprivation therapy, otherwise known as ADT. And some of the overview of our talk, my talk this afternoon is talking about anti-testosterone therapy. Many times you'll hear people use the word, we're going to give you Lupron, although there's many different brands and formulations of androgen deprivation therapy. You'll hear a lot about these complicated sounding names like abiraterone, enzalutamide, apalutamide, darolutamide. It gets very overwhelming for patients and caregivers alike to try to keep track of these different medications. We'll talk a little bit about chemotherapy, docetaxel and cabazitaxel. Dr. Gross spoke about PARP inhibitors. I'll try to put that into context of these other therapies that you've heard about. And then we'll talk a little bit about immunotherapy. And then lastly, I'd like to touch on one of the things that I find the most exciting coming up, hopefully the early part of next year, is something called radioligand therapy. The key thing, of course, many men can be cured of prostate cancer when it's caught early, and it's somewhat difficult to predict. But as we all know, sometimes, despite the best intentions of having surgery or radiation to treat prostate cancer, at some point for some men, the PSA, you're following it out every 3 months. Sometimes eventually out to every 6 months, the PSA starts to rise, and the question is, well, what do we do next? What we want to do, of course, is try to determine where the prostate cancer is when we make that determination in this particular setting. So one of the key things about this definition is that we see a rise in the PSA, but there's no signs of cancer in the body based on conventional imaging. So we look at a CAT scan or a bone scan in many situations, and we don't see evidence of disease. Now, the thing about this area of disease state is that it's changing. There's newer technology. You've seen some of the other speakers talk about different kinds of PET scanning. and it's really a much more functional type of imaging that we're doing to try to detect prostate cancer at an earlier and earlier state. And so the exact definition, I can imagine in the next 5 years there's going to be less and less men with biochemical recurrent only disease, because we will be able to detect prostate cancer when it recurs at a very early point, perhaps only in 1 or 2 areas in the body. Sometimes you'll hear us refer to that as what we call oligometastatic. So we might see just one lymph node or one spot in a bone at a distant location. So you'll probably see less and less folks with this particular, that fall under this category. So you know, if the PSA starts rising after radiation, a couple clinical pearls I'd like to communicate to folks is that you know, there's still some normal prostatic tissue, so it's expected after radiation, sometimes 6 to 9 months later, that your PSA will come back up. But what matters is the rate of rise and how high it goes before we determine for sure what our clinical concern is for if there could be actual prostate cancer present. Sometimes after radiation you can consider prostatectomy, or you can use other forms of radiation such as brachytherapy or what's called cryotherapy, where they sort of freeze any remaining prostate cancer cells that may be in the prostatic bed after surgery or after radiation. So we'll follow the PSA at 3 to 6 months intervals, but if the PSA is rising, you know, especially after surgery, greater than 0.2, then we would consider trying to treat prostate cancer with radiation and also anti-testosterone therapies. One technique that I've adopted into my practice in the last 5 to 7 years, I would say, would be if the PSA is rising after surgery or radiation, and there is no signs of recurrence in the body systemically, one option to avoid using anti-testosterone therapy is to use, or full anti-testosterone therapy is to use Castrate, which is a generic drug, very inexpensive, to try and block some testosterone in the body, but not all the testosterone in the body. I think one of the most difficult things to do as a physician is to, in this particular field, is to tell folks that we need to take away their testosterone. Because for a lot of men, testosterone helps our strength, our bone health, our cognitive strength, and of course our sexual function. So we have to be very judicious about the use of androgen deprivation therapy. As a field, we're sort of getting away from just blanket giving everybody androgen deprivation therapy. We'd like to try and be very selective about those situations. And the nice thing about Castrate, in the right setting, it is something that could help avoid having to give people complete total testosterone deprivation therapy. And so the question is, who needs to go on these Lupron shots when in the setting of just when we find the PSA rising, no sign of cancer elsewhere? We look at high-risk features, and these are some good things to keep in mind. It's not one size doesn't fit all. So if your PSA is doubling in less than 10 months, if your Gleason score was 8 to 10, or if the interval from the time that you had your initial surgery or radiation to the time that the PSA starts to rise or keep rising is less than a year and a half, then those 3 factors are considered higher risk. And so we know from our clinical studies that randomized people between total testosterone blockade and just continuing to watch, that you can avoid having complications of metastatic disease and improve their survival. So if you have high-risk features, I'm more inclined to talk to you about using earlier on medications like Lupron. But if you don't have any of these features and your PSA is rising, but it's rising very slowly, over 1 to 2 years, I definitely feel like you don't need to go on Lupron and experience all the potentially terrible side effects of that type of medication. So that's an important teaching point that I like to talk to folks about. And the same thing goes with another concept that I want to talk to you about, which is intermittent versus continuous approach that you probably may have spoken to your docs about. If you have these high-risk features, or you were to have known sites of disease, the general feeling and from the literature is that there's a survival benefit to stay on continuous blockage of testosterone. But if you don't have any of those high-risk features, again, and your PSA is rising slowly, but you do feel the need, to do something about it, you can use an intermittent approach. And that is something where you get to give your body a holiday from the anti-testosterone treatment. So you might want to do an injection that lasts only a month or 3 months. And hopefully, expectingly, the PSA would come down, and then you just watch. And the PSA might start to rise again, but if it only gets to maybe half of where it was when you decided to start therapy, you could go a year or 2 or even 3 years without having to have androgen deprivation therapy. And there are various approaches to this. There's, in fact, a new oral medication that's available, a Rigavix that can block testosterone a little bit quicker on and off mechanism. So there's a couple of really ways to sort of finesse that scenario without having to go all in. It's important to remember that there's the last sort of comment I have here about is that there is a situation of what we call castrate resistance. That was one of those definitions I threw up on the first slide. So, when we're using medications like Lupron, we're really blocking testosterone production from the testicle. So, and for many men, that works for many, many years at controlling this disease and helping even cure the disease in certain situations. But in some situations, eventually, these prostate cancer cells, unfortunately, learn how to grow around the fact that we've completely blocked testosterone. And so there have been several studies, big studies that have been published recently to show that in a situation where you've got a rising PSA, you're on Lupron, but you don't have any signs of disease elsewhere in the body, that use of these, one of these 3 medications can help delay the time to which you develop metastatic disease. So this class, I'll just take a moment to mention that when you see these types of medications, so as I mentioned, Lupron blocks testosterone production. These drugs basically block any other. There could be remaining testosterone in the body, either being produced by the cancer cells or by peripheral tissues of our body or our adrenal glands. These medications, they're pills, they actually go inside the cells, the prostate cancer cells. They block testosterone from binding to its receptor and signaling the cancer cell to grow. So they're really imagining, you take your Lupron, your testosterone falls very low, and these pills are blocking any of that remaining testosterone that's out there. So that's an important mechanism. So let's take a moment to change gears a little bit. We were just talking about the PSA coming back, but no signs of cancer in the body physically on our imaging studies. Unfortunately, even in this era of PSA screening, there are many men that for whatever reason don't get a PSA, or they have been getting a PSA checked and they're very religious about their general health, but unfortunately, perhaps the disease is a more aggressive variant or type, and folks come in with signs of more advanced cancer. And so that's really, as a physician that cares for people with prostate cancer, at that point we're thinking we've got a lot of good treatments to help this disease get in remission. And the question is, what do we use when and what sequence? And the fascinating thing about this situation is that the treatments have changed over the last decade. When I first started practicing, everybody was offered the same thing, which was blocking of testosterone with a medication like Lupron, and that was it. But now, as you may have heard from some of the talks today, that we've been moving some of our other treatments that have come out earlier and earlier to improve the survival of men in this situation. So basically, the first teaching point here is in this situation dealing with recurrent disease to the bones or lymph nodes, we're going to use Lupron, and then we're going to also use a medication. One option is abiraterone, as well as another option are these other pills that block testosterone. Just to set the stage here, these pills that block testosterone in the cancer cell, there's also another type called abiraterone that blocks additional areas where testosterone can be produced in the body. There is a little bit of a difference that I like to talk to folks about, which is this medication tends to have less physical side effects on folks. We don't really have a lot of head-to-head comparisons, but this drug called abiraterone or Zytiga blocks testosterone being made, for example, in the adrenal glands and other peripheral tissues. Whereas these drugs go into the cell, like I was explaining, but they can also cause a little bit more muscle weakness. Sometimes they can cause some sleepiness because there's some penetration of the medication into the central nervous system. So there are nuances and differences that aren't necessarily haven't been teased out in head-to-head comparison studies, but we've just learned from prescribing them to folks and looking at different patterns. So it's something important to ask your doctor about. But the bottom line is using these pills in addition to Lupron helps improve survival and reduce complications from this disease. In the past, we would have waited until the disease had already become resistant to the Lupron before starting them. So there are situations where we might use chemotherapy up front. Like I was mentioning, 10 years ago, we were sort of going through our options one after another. But if I meet a person that has a very aggressive behaving cancer, it's rare, but it can still happen where the disease appears in the liver or many areas throughout the bones and folks are very, very sick. There's definitely good proof that it's not enough to just give Lupron. You want to highly consider being more aggressive by adding chemotherapy up front with that Lupron, just initially in the first 4 to 6 months of getting started on therapy. And this was proven in head-to-head randomized trials comparing Lupron versus chemo plus Lupron. I mentioned a newer medication on the block called Relugolix. It's basically a pill form of Lupron. Another one that's hard to pronounce, but it's definitely been shown to have sort of a quicker on and off mechanism of action. So for folks that are really concerned or have had problems with very low testosterone side effects, this may be another option to ask your doctor about as well. So finally, the rest of the slides I'll talk about are what to do in castrate-resistant disease. So this is a situation where that we've been using Lupron, and the PSA has come down nicely, and it's been working very well. But now the PSA is starting to go up, or perhaps on CAT scan or bone scan, we're seeing new lesions. And unfortunately, as we all are aware, prostate cancer sometimes cannot be cured, and it's a disease folks have to live with. And in that situation, eventually, somehow, and we don't understand exactly why, but these cancer cells learn to grow around the fact that we've knocked testosterone way down. And so we have a couple of other tricks of the trade I like to refer to that can help keep the PSA down and give folks more options. So I want to kind of go through them with you guys. One older trick is to use a steroid such as dexamethasone or prednisone. Sometimes adding that to our anti-androgen therapy can help. Another trick is that with some of our pills that block testosterone, and this may sound, it's kind of a little bit of a scary concept to me as a doctor and definitely to patients, is that the pill that you've been taking to block testosterone can sometimes actually turn on the cancer cell. So That tends to be more well described with Casodex, but about a third of men in some studies, if you take away the Casodex or the biclutamide, you can see excuse me, you can see the PSA go back down. So it's only about a third, but still something you want to at least try before moving on to your next line of therapy. So, and then I've mentioned this several times about these other pills that block testosterone differently. Those are options. And then I would say just a little bit of comment about the fact that if we have exhausted all of our anti-testosterone therapies, then certainly one option is chemotherapy. And those drugs go by the name of Taxotere and Jevtana. One thing I like to try to explain to folks is, with regards to chemotherapy, is that you definitely need to be fairly hardy medically, and you don't want to have very severe heart problems or lung problems. There's a higher chance of complications if we were to launch into chemotherapy. However, the old days of being like very, very sick or throwing up and all the things you can imagine about chemotherapy, for the most part, aren't nearly as frequent as you might imagine because of all the supportive care that we have. So we have a lot of good anti-nausea medications and other medications that can help make that process a little less harsh. One question that gets asked a lot, and we finally have a little bit of an answer to, was patients would say, well, I've been on this one pill for anti-testosterone therapy. Let's say, just to throw out an example, I've been taking Zytiga for my anti-cancer treatment, along with Lupron, and my PSA is going up. The question is, should I switch to one of these other pills? It's definitely still an option, but you need to be careful because there's a very low chance that switching from one pill to another pill will actually make a major impact against your disease. So if your disease is starting to behave quite aggressively, I generally tell people not to try to make that switch. If it's behaving more slowly or indolent, I might, we may consider that together. But there's been a recent study published within the last couple of years called the CARD study that showed that switching to a chemotherapy drug can help improve survival and what we call relapse-free survival. Just a word, we've already spoken about immunotherapy in the last session, but there's something called a dendritic cell vaccine called Sipuleucel T. It's a very laborious procedure. It's only felt to be helpful for folks who have a rising PSA that have sort of exhausted your androgen deprivation therapies, that are not sick from their disease, because you generally don't see a fall in your PSA. You don't see a rapid sort of clinical benefit. So it's something that I personally don't really pursue often with my patients for that reason. But there are a few settings where it may still be used. You might find it still offered in some places. So we talked a little bit about genetics, so I'm going to skip through this slide, but just to sort of rehash what Dr. Gross very eloquently discussed, is that we do test men, both their family genes, or what we call the germline, as well as the cancer cells themselves. We want to check the genes that are involved in perhaps in some of the cancer growth there. The one point that I'd like to stress is that it's possible if you test just your tumor, you're going to miss a gene that you may carry in your own germline that you might be inheriting or passing on. So for the most part, like Dr. Gross was mentioning, it's really important at some point in your trajectory and your journey, it's important to test both your own cells that you were born with and also test the cancer cells for genetic markers. That's an important teaching point. And so the PARP inhibitors, we talked about Lynparza, as well as rucaparib. Those are pills that block DNA repair mechanisms and drive the cell into cell death. So you really want to try to identify men with BRCA2 in particular, But there are a bunch of other genes that you can see listed up here that also give sensitivity to the cancer cells to PARP inhibitors. You'll see here, this is really impressive. If you have a BRCA2 mutation, you can get benefit from Lynparza and drugs like it for up to several years in some studies. So with these other mutations like CHEK2 and ATM, PALB2, the benefit is not as profound, but it is definitely helpful as well as a non-testosterone type treatment. Okay. A couple words about bone metastases. So, it's very important to protect our bones. Holds us up against Earth's gravity. So, it's very helpful. So, metastatic disease in the bones can be quite painful, as we can all imagine or have experienced. Using things like ibuprofen or Advil can help with anti-inflammatory. Sometimes steroids help with pain, bone pain. Radiation, a single dose of radiation to a couple of sites can be helpful. I didn't hear Dr. Spratt's talk, but I know that we are also treating metastatic disease with higher doses, more specific forms of radiation, especially if there's only 1 or 2 lesions in the body, to try and, especially at that site, but overall get better control over the cancer. In situ, we call that, stereotactic radiosurgery. There are situations where that I wanted to comment on about the use of these medications. You may have seen commercials for Prolia or Reclast, which are these medications that block the degradation of the bone by the cancer cells. They're definitely indicated in castrate resistance. So you're on Lupron, your disease is getting worse. Everybody should be offered this anti-bone resorptive therapy. I also still consider it, even in patients where Lupron is working well, even though there's not necessarily a quote-unquote survival benefit, if you're going to be on Lupron for several years, that can affect your bone health. So it's very important to protect against osteoporosis. So at some point, I might want to consider a bone density scan in that setting, or just go on a dose of Prolia twice a year, very easy injection to help protect your bones. Make sure your calcium and vitamin D levels are being addressed. We'll talk about a moment, only briefly mention something called Radium-223. This is a liquid radiation, so to speak, so it's an IV infusion of something called radium, which actually tracks specifically to the bones and releases a low dose of radiation to the bone marrow, to try and kill any surrounding cancer cells. It's been helpful with regards to reducing pain from prostate cancer. But it has complications, and we've had so many new advances in treating prostate cancer that we don't use it as often as we used to. And as I'll mention in the end, there are other therapies that are looking a bit much more promising. So, but I just wanted to mention it's something you may want to ask your doctor about. So, say I didn't skip a slide, no. Okay, so I wanted to finish up about something called PSMA targeted radiotherapy. Dr. Gross's last slides were showing you targeting this protein that's present on the surface of the cancer cell here in this cartoon. This is the surface of the cancer cell. This blue character here represents something called PSMA. And basically, scientists have figured out how to unlock PSMA or attach to PSMA, and they piggyback a radiation to this molecule. It gets absorbed inside the cancer cell and delivers a lethal dose of radiation to that cancer cell while sparing the rest of the body. And it's not completely sparing of the rest of the body, but it's much more targeted to the cancer cells than your normal tissues. So that radiation therapy is called lutetium-177, although there are other radioactive elements that are being used as well in clinical trials. This one is the closest to approval in the United States, And we're hoping that it will get approved within the next, in the early first quarter of 2022. So, so we've already set up, I know at UH we have a PSMA PET scanning. So that's the first step in utilizing this technology. So we don't give everybody this therapy. We want to only give it to men who have exhausted some of the treatments that we've talked about already this afternoon, and that their cancer cells have PSMA on it. So if you don't express this protein, there's no point in giving you this treatment. 80%, 85% of men with prostate cancer will have PSMA expressed on their cell surface, so it thankfully is an option for most men with prostate cancer. But it's very important to have the scanner set up and running before this as this treatment comes online. So we're, at least I can tell you, we do have the machine. It's running. It's working. And I can, and your doctor could refer you for that. We'll talk maybe afterwards about, you know, who should get this PSMA PET scan. When is it helpful? When is it not helpful? Who's going to pay for it? There's a lot of questions that I don't necessarily have the answer to yet, but I hope to learn about as the year goes by. So PSMA targeted radiotherapy, this was based recently published in the New England Journal of Medicine. If you wanted to Google that, you could, called the VISION study. And it was a randomized study of this radiation treatment compared to other, what we call best supportive care, or other standard treatments, if you will. There were 800 patients enrolled in the study. They screened over 1,000 patients, and 800 qualified. So it was, most of the folks did have the PSMA expression that was necessary for the study. You had to have had prior androgen deprivation therapy. So the first question I thought of when I saw this technology is, could we use it instead of having to give people Lupron? And so far the answer is not yet. Just right now we've only studied it in the setting of after Lupron therapies have failed or are not working as well. And it was a pretty impressive, for a randomized study, it showed 15-month survival versus other standard therapies. And there was reduction in pain. There was a 50% response rate. And remember, this study is in folks who have really exhausted all known treatments. So we're taking folks in a very difficult scenario. And so to see this kind of a survival difference in that setting is impressive to the medical community. Just a little bit about how this treatment will be given. It'll be given by the Department of Nuclear Medicine at a major academic medical center when it first rolls out. It'll be infused every 6 weeks for between 4 and 6 doses. So on the VISION study, if you were responding and tolerating it well and you received 4 doses, you were allowed to get 2 additional doses. So every 6 weeks. This picture is, I grabbed it from the internet after searching through thousands of pictures, in full disclosure. So I thought it might help. So it shows a gentleman here who's gets a PSMA PET scan, so you can make out that this is his head, and this is his liver and spleen, this is his kidneys. He's kind of urinating out the PSMA dye, so to speak. And all these black spots here are representation of where the cancer is spread to the different bones. I don't see much in the liver, but you can see down here, some of this may be intestinal excretion of the radio-labeled dye. But right now you can see in this picture here, his PSA at that time was 458. And then after 3 cycles of this PSMA radioligand treatments, this PSA has fallen to 158, and a lot of the spots in the bones have resolved. Not completely, but it's only after 3 cycles. This is somebody with a little bit less disease, it looks like, and his PSA is 61, and it falls to 10 after 3 cycles. So this is looking at a CAT scan. This sort of red shows a lymph node, a large lymph node, sort of before and after treatment. So we're starting to see images like this appearing in the medical literature of this technology. I think there's going to be a lot of questions when it first rolls out, such as, who's going to qualify for it, who's going to pay for it, how will it be administered, where it will be administered. But it's a very exciting prospect for folks in this situation. This just follows up some of these graphs that we like to show in our medical literature, showing the blue line represents freedom from progression or overall survival in this graph compared to people that are getting the standard treatment. So you can see that as time goes on, let's say 6 months, 8 months out, you see a lot more folks have a lot less folks have progressed compared to those that have progressed. So Dr. Gross mentioned immunotherapy that we use, and unfortunately, right now in prostate cancer, we're using it in a very small subset. He mentioned the folks that have microsatellite unstable cancers based on genetic testing. It's only about 2 to 3%, so it's very, very rare that we can use drugs like Keytruda and Opdivo. But basically, you see here, this is the cancer cell, this is the T cell. Our T cell has engaged with the cancer cell through this complex here, but the cancer cell has deployed this molecule to block the T cell. So then you give drugs like Keytruda and Opdivo, and there are many others now on the market, and this blocking is now interrupted, and the T cell can then attack the cancer cell, resulting in cancer cell death. Dr. Gross mentioned the BITE technology to force the T cell into proximity of the cancer cell and force that attack on the cancer cell. There's another technology which is even more labor intensive than what Dr. Gross had described. It's called CAR T cell therapy. And this sounds a little bit like science fiction and maybe a little scary, that you're introducing a virus into our own T cells. The virus delivers the code to our T cell to basically engineer the T cell to engage with the tumor cell and kill the tumor cell. This has been approved in treating leukemias in children. It's been approved in adults with lymphomas. But they are working on it in other solid tumors, prostate cancer being one of them. And the process involves basically you go to a medical center and they do a procedure called apheresis, where they basically extract your blood, pull out your blood. They spin down, your blood goes through a centrifuge, and they pull out your white cells, your T cells. They return your blood at the same circuit. So you go home with pretty much the same amount of blood that you came in there with. They pull down your T cells, and they basically send your T cells in a bag to a company. And then this is what happens in the lab. They infect your T cells with this virus, a virus that is disabled, from causing infection. But it sends this code in to tell the T cell what to do. So it's sort of like how do you train a T cell or train a dragon? So thank you very much. I covered a lot of broad topics this afternoon. So if you have any questions, feel free to jump in. Thank you.
Bad guy coming up with questions.
Oh, man, I had such an easy job until now.
Yes. So a lot of us have heard of Provenge, and Provenge kept swimming around in my brain when you were talking about the CAR T cell.
Right.
So maybe just explaining the difference between those two, because it sounds a lot alike.
Right. There's so many immune therapies. Dr. Gross had spoken about BITE technology. And then, even 10 years ago, Provenge was available. I've only had 2 patients that I tried to get through that process, but it's also very labor intensive, just like CAR T is. But so basically, they all with the Provenge or Sipulus LT, they're basically doing the same process of this leukapheresis procedure where we remove some of your white cells. In this case, they're called dendritic cells, just a different type of white blood cell. And then they are basically sending those white cells to a lab, and they're trying to expose those dendritic cells to PSA type derivative, and giving various other chemicals, adjuvants to stimulate the dendritic cells. Then they send those cells back to you and infuse them. And it's 3 or 4 infusions. But it's very labor intensive. You don't see the fall in the PSA. You can't use it in folks who have more aggressive behaving disease. So for those reasons, we don't tend to use it that often. We're hoping with these more modern therapies like BiTE technology, which more directly engages the cancer cell, or in this case, CAR T therapy, that we'll see more robust responses. We need to see the PSA go down. We need to see the CAT scans get better, and not just hope that it's working. So that's the big difference.
The first question most of the patients that I see with prostate cancer say, they don't even want to talk about anything else, but they'll be like, what's my PSA? What's my PSA? And fortunately or unfortunately, now our electronic medical record system releases this information to the patients before you get a chance to see them, as well as other testing, which I think has some good things and bad things to it. But at what point, with patients with advanced cancers, do you say we have to ignore what the PSA is telling us?
That's a great question.
And how do you monitor those patients? I think a lot of people want to know that.
Yeah, PSA is sort of a poor man's test, and it's for the most part all we have, even in the year 2021, 2022. We have CAT scans and bone scans. There comes a point where the PSA is going up. We've maybe exhausted some of our standard treatments, and we have to be careful about how we interpret the PSA. So, for example, after you start a new treatment, sometimes, like for example, chemotherapy, your PSA can actually go up before it goes down because we're killing those cancer cells and it's releasing PSA into the blood. PSA is not dangerous to the human body, so it's not. And also, one person's PSA this can't be interpreted the same with another person's PSA. So, so you might have I've had patients with PSAs of 400 or 500, 700, and when you do a full scan, you might find 1 or 2 enlarged lymph nodes. Otherwise, they feel fine. They're like, Doc, I don't know why I'm here. So not everybody worries to the same degree over their PSA. And so the question is, do you treat those individuals if you know that their treatment is going to prevent them from being able to lift their motorcycle so they can go on that ride they've always wanted to take across country? I've had conversations like that in my office. So you really, and the other thing about the PSA goes back to one of my earlier slides. You really have to interpret the PSA within the context. Is the PSA going up by 1/10 of a point every 6 months, every 9 months or a year? That's a situation where you want to be careful. You don't want to get into over-treatment because some of our anti-testosterone therapies can really affect your quality of life and your length of life if you get a complication. So, yeah.
And of course, with the intermittent versus continuous androgen deprivation use, I think the intermittent, and you can correct me if this is not true, a big con against that in the past has been, well, if you do intermittent, does that allow the cells, the prostate cancer cells, to evolve and mutate and become more resistant than, say, if the patients are on continuous?
Right, but you could argue, yes, you can, and you can argue the same way that if you're on continuous, that they'll evolve to become more resistant. So we've needed that's where randomized clinical trials are so important. And there's actually been a number of published randomized clinical trials of intermittent versus continuous. And the major teaching point that I like to, my take-home message there is that if you don't have evidence of metastatic disease, it's just the rising PSA, and the PSA is rising very slowly, then there's no survival benefit to staying on continuous androgen deprivation therapy at all. And if you're watching carefully your PSA, the rate of rise, you can do it safely, you can do an intermittent approach. On the flip side, my former mentor at University of Michigan was a big leader on this study that was published in the New England Journal of Medicine, that if you have widely metastatic disease on imaging and your PSA is going up at a pretty fast clip, doing intermittent approach is definitely not appropriate, because we saw in that trial that patients lived much longer and had less complications from their disease if they stayed on the Lupron, continuously in that setting.
Anybody else have questions? Well, thank you. That was great.
Thank you, guys.
Thank you.
Appreciate it. Yeah, thank you.